So it is an honor to have our next speaker. He is the Deputy Director of the Columbia Lighthouse Project. He also serves as Assistant Professor of Clinical Psychiatric Social Work in Psychiatry in the Division of Child and Adolescent Psychiatry at the Columbia University Bachelor's College of Physicians. I'm sorry, did I get that correct? Fantastic. And physicians and surgeons. He holds a Master of Social Work and is a licensed clinical social worker. We're a big fan of clinical social workers. Please join me in giving a very warm welcome to Adam Wilson. Thank you.
Happy to be able to join you this morning. Dr. Kelly Posner, who is my boss, sends her regards. She is very excited to be working with UK and with the entire state here. But I'm going to talk with you this morning about the Columbia Suicide Severity Rating Scale, and we'll go through an actual training on how to use it, what the different options for tools are, and a little bit about how it was developed, and how it will help you make what we think is a tremendous difference in your ability to identify folks who might be at risk for suicide. Before I do any of my talks, I always remind audiences that suicide is a very personal topic for all of us, and it's not always easy to talk about. It impacts all of us in one way or another. Some of us may have lost a family member or a friend or a patient, a coworker to suicide. Some of us may be survivors of our own suicide attempts. And so I want you to pay attention to how you feel today. Feel free to take some space if you need to, and do something nice for yourselves tonight or over the next couple days, because we don't spend enough time taking care of the caregivers, and if we don't take care of each other and ourselves, we're going to burn out, and we need you doing this important work that you're so good at. So please take care of yourselves and take care of each other. Suicide is actually a global public health crisis. It's not just here in Kentucky or here in the United States. We lose about 1 million people a year to suicide across the world. And that's more people than war, homicide, and natural disasters combined. It kills more people in the United States than car crashes. Yet we see all kinds of public health efforts to prevent car crashes, billboards that remind us to buckle our seatbelts and places we can pull off the road to text. But we don't see that for suicide. And that's why Thomas Insel, the former director of the NIMH, calls suicide the under-recognized public health crisis, because it doesn't get the attention that these other methods, forms of death are getting. It's actually the #1 killer of teenage girls across the globe, and the second leading cause of death in youth and young adults in our country between the ages of 10 and 34. And we've actually seen an almost doubling over the last 7 years of suicides of our youngest victims, those in the 8 to 12-year-old age range. So it's not impossible to have a suicide in an elementary school these days. And we know a lot about how our youth behave and how they think because we survey them. And the Centers for Disease Control does what's called the Youth Risk Behavior Survey every other year. And what our teens tell us year after year is that about 7 or 8% of your average high schooler will make a suicide attempt every year. And so if you have a school of 1,000 kids, you can expect 70 or 80 kids in that high school to make a suicide attempt. And I talk to lots of principals and superintendents, and when I tell them this and I ask them, do you know who those kids are? The vast majority of those kids, they don't know. They haven't identified them. And they are surprised by the sheer numbers of students who are suffering and are unknown to them. And you know, there's actually a strong relationship between suicide and school violence. So the Secret Service did a study back in 2002 of school shooters, and they found that almost 80% of school shooters had a documented history of suicidal thoughts or behaviors prior to the attack. And at least almost a third of them reported that this was in fact a suicide attempt. And yet we know that only a third were ever evaluated, and less than 20% ever were given a diagnosis. So again, we have opportunities where we might be able to prevent not only individual suicides, but also some of these mass tragedies from happening, and we're not taking advantage of it. Now, while we lose about 45,000 adults these days every year to suicide in the United States, that's really just the tip of the iceberg when it comes to suicidal thoughts and behaviors. So for those 45,000 deaths, we have about 1.5 million attempts. So about 25 people attempt for every one death. And about 10 million American adults will seriously consider suicide every year. So the numbers of people thinking about it and making attempts far outnumber those who actually die. And one of our main jobs and how the Columbia tools can be helpful is in figuring out which ones of those folks who are having those thoughts are the most at risk for going on and making an attempt and even making a lethal attempt. Now, in Kentucky, you have the 23rd highest rate of suicide in the United States. Of the 730 gun deaths you experienced here in 2017, 470 of those were suicides, about 2/3, 2 out of every 3. And since 1999, you've averaged about 23% higher than the US national average. 15% of suicide deaths here in Kentucky are veterans. And as far as the methods of suicide being used by Kentuckians, for both men and women, firearms are the most common method being used. 2/3 of men who die by suicide are using a firearm. Half of women who die by suicide are using a firearm. And our heat map for suicide rates in Kentucky actually looks pretty opposite to the heat map that you showed for opioids. We see higher rates of suicide in your western parts of Kentucky. And Kentucky, like the rest of the United States, for 10 to 34-year-olds has suicide as the second leading cause of death, and the fourth leading cause of death for middle-aged adults here in Kentucky. And as far as what Kentucky students said the last time they were surveyed by the Youth Risk Behavior Survey, they surveyed about 2,000 high school students back in 2017. And almost 20% of the girls and 10% of the boys reported seriously considering suicide, with 9% of the girls and 6% of the boys saying they made an attempt. So that's the same 8% average that we see in the US. And of those 2,000 students, 200 of them, or 10%, identified as lesbian, gay, or bisexual, with 40% of those students saying they seriously considered suicide, and almost a quarter of them attempting in the past year. So one of your very high-risk categories of kids are your lesbian, gay, and bisexual students. Now, it's not just a mental health issue. We see increased risk for suicide across all medical illnesses. So if you take just cancer patients, for example, one study found 18% of cancer patients had suicidal thoughts independent of any depression that they might have also had. And a recent study showed that if you have back pain, brain injury, cancer, COPD, epilepsy, migraines, sleep disorders, they all increase your risk for suicide. And so we need to be looking for folks who might be at risk, not just in our behavioral health centers, but also in all of our medical clinics. And it's really a crisis wherever people are doing high stress jobs. It's often the leading cause of death of first responders themselves. We lose more police officers to suicide than we do to crime. We lose more firefighters to suicide than we do in fires. And they have rates that are similar to those in the US military because of the risk for post-traumatic stress that they also are experiencing. It's the most common cause of death in our jails, and jail inmates have suicide risks that are 3 times greater than the general population. Now, while the greatest rates of numbers of suicides happen in our cities, the highest rates of suicides happen in the rural parts of the country. And there are a couple reasons for that. The first being that in the rural parts of America, we tend to see populations that are spread out across a great distance, and that often gives them poor access to mental health care or medical care. Before I came to Columbia to help disseminate the Columbia tools, I was the director of youth suicide prevention in the state of Georgia. And we would see that when families were struggling to make ends meet, when they had someone who was out of work, they didn't use the gas that it costs to go 45 minutes for a mental health appointment for their family, right? It becomes a low priority. The other thing is that if you compare all the demographic factors to suicide rates, the one demographic factor that most closely tracks with rates of suicide are rates of gun ownership. The more guns you have in a community, the more suicides you have, regardless of any other issues that might be going on. And this data set makes that very clear. This is a look at the states with the highest rates of gun ownership and compares them to the states with the lowest rates of gun ownership. Kentucky is here in this high rate group. And in that high rate group, there are guns in 56% of the homes. In the low state group, there are guns in 20% of the homes. And when you take enough states so that you have population groupings that are equal, you see that the number of non-firearm suicides are pretty close to the same in both groups. About 8,200 for men, 8,800 for men, about 3,500 for women. But the number of firearm suicides that you tack on top of that are 4 times as great for the men, 4,000 compared to 16,000, and almost 10 times as high for women, 300 compared to 3,000. And so just living in a community where you have easy access to something so lethal as a firearm increases your risk of dying by suicide, no matter what else might be going on. Now, this is breaking but not very surprising news. It turns out that a lot of our opioid overdose deaths are in fact suicides and aren't always getting identified as suicides by medical examiners or coroners because they don't always have the information about intent that they need to make that assumption. And it makes a lot of sense when you think about it. What often gets people into opioid addiction in the first place is having a chronic pain issue where they're prescribed it, and we know that that increases risk for suicide, or self-medicating a mental health issue. So they might have anxiety or post-traumatic stress, and they might be using opioids in order to self-medicate a mental health issue. And you know, as a result of the high rates of opioid overdose deaths and suicides in middle-aged white American men, we've actually seen the average length of life of Americans overall decrease for the last 3 years, compared to every other developed nation in the world where it's been constantly increasing. And there is a strong connection between suicide and addictions. We see opiates present in 20% of all suicide deaths. We see alcohol involved in 22% of all suicide deaths, and acute alcohol intoxication in at least 30 to 40% of suicide attempts. 4 out of every 10 patients seeking treatment for substance abuse also report a history of suicide attempts in their past. And you know, we used to think that suicide affected, a handful of people who, were in the family of the person who died. But what we know now is that if you look at all of the concentric circles around somebody, it affects about 135 people for each death. So you look at family, you look at friends, you look at coworkers, and the spheres of influence and the ripple effects of having just one death are pretty significant. Now, of course, I don't need to tell you this. The biggest cause of suicide is a heritable, treatable medical illness called depression, caused by changes in brain chemistry. And unfortunately, depression is on its way to becoming the most debilitating disease in the world. It's already the most debilitating disease in the United States and in other middle and high income countries. It actually costs our nation over $40 billion a year in lost productivity from people calling out of work sick for being depressed. And that doesn't even count the impact that it has on their families or the impact it has when people who are depressed are coming to work and just not producing up to their abilities. So suicide not only affects individuals and affects families, it actually affects our economy in significant ways. Now, while we know most people with mental health issues aren't suicidal, The vast majority of people who die from suicide have a mental health issue at the time of their death. 90% of them do, and 60% of that's depression. But the undertreatment of mental illness is pervasive in our country. It's estimated over half of the people who need treatment receive no treatment or inadequate treatment. For kids and teens, it's about 70% of kids and teens with depression go untreated. And we know that more than 8 out of 10 college students who die from suicide were not involved in any kind of treatment prior to their deaths. So we're not identifying people who need this kind of care, and we're not getting them that kind of care that we know that they need. And a big part of that has to do with the stigma that still exists around suicide, depression, and other mental illnesses, especially for groups like men or folks who are in our military. Now, there are a few myths about suicide that get in the way of the work that we do. The first being that if someone's really suicidal, they're probably going to kill themselves at some point, no matter what you do. You can't really stop somebody if they want to kill themselves. We know that multiple studies show that more than 9 out of 10 people who make suicide attempts, even very lethal attempts but survive them, don't go on to die by suicide later in life. In fact, it's a symptom of mental illness that comes and goes with levels of stress. So if you help somebody through that peak time of being the most suicidal or the most stressed or hopeless, they may never get that hopeless ever again, and you may actually make a lifelong difference for them. Then asking a depressed person about suicide might put the idea in their heads. I know that when I first graduated from social work school, my first job was in an inner city mental health clinic in Boston working with adolescents. And I was afraid to talk to those teenage kids about suicide, asking them if they've ever tried to kill themselves before, if they ever thought about killing themselves before. I worried that if I just started talking about it, maybe it would normalize it in some way for them, that it would, make it more likely they might try. But what we know from the last decade of research is that that's absolutely not the case. That talking about suicide does not increase anybody's risk for making a suicide attempt. Even a study that looked at screening an entire high school of kids did not see an increase in the thoughts or behaviors of those high school kids after they were all asked about this. In fact, when you do talk to somebody about suicide, if they've been thinking about it before, they're going to be relieved that they can finally talk about it. I can't tell you the number of kids who say, "Are you reading my mind?" when you ask them these questions. And if they haven't thought about it before, talking about it's not going to make them start to think about it, right? They probably already are thinking about it. Then someone making suicidal threats won't really do it. They're just looking for attention. We do know that there are some people who will have a low-level wish to die that is their baseline, that just doesn't go away. This is common in folks with borderline personality disorders, for example. But even those folks who say it a lot, we need to take it seriously every time they say it, because the time that we don't take it seriously and give them the attention they're looking for may be the time that they feel hopeless and go on to make an attempt. So we need to listen and take it seriously when we hear it. And there's no point in asking about suicidal thoughts if someone's going to do it, they won't tell you. We know that many folks will tell you if you ask them. I'm often pleasantly surprised by how honest people are on these kinds of questionnaires. And that's because we think, because ambivalence is characteristic in 95% of people who are suicidal. So the wish to die that comes with being suicidal is fighting up against the human species' instinct to live. It's actually very hard to overcome that instinct to survive and to make an attempt. And it's why we see contradictory statements in folks who are suicidal all the time. I heard about a man who had made a suicide attempt, and in that same week, he also booked a family vacation. So he was thinking about something positive in the future, almost at the same time that he was thinking about dying. And it's also why we see about 80% of people give some kinds of hints or warnings to family members or friends. It's often after a suicide, when we do a psychological autopsy, we find that lots of people knew lots of little pieces about how much this person was suffering, and they just didn't put those pieces together in time to be able to rescue the individual. And we know that people want to be asked because they tell us. We work with some with a guy named Kevin Hines. If you've never heard of Kevin, you should Google Kevin and hear him tell his story. Kevin is a survivor of jumping off the Golden Gate Bridge. It's lethal 99% of the time. He's one of only a handful of survivors that can still walk after his attempt, after numerous back reconstruction surgeries. And he tells his story. He was a 19-year-old adolescent with a psychotic depression, and his voices were telling him that he needed to die. And so he was able to make a pact with himself because of that ambivalence, where he said to himself, if just one person asks me what's going on, I'm going to tell them everything. And so he gets on the bus to go to the bridge that day, and he's crying the whole way there. Nobody says anything to him. He gets to the bridge, he walks up and down the bridge 2 or 3 times, still nobody approaches him. Finally, a woman's approaching him, and he thinks, this is it, I'm going to get some help. And when she gets to him, she says, will you take my picture? And so he takes her picture 4 or 5 times, gives her back her camera, decides that nobody cares, and he jumps. And what he says is that as soon as his hands left that railing, he instantly realized everything in his life he thought was unfixable was fixable except for what he had just done. And what he says now when he goes and gives talks is that what we need is a society where people are not afraid to approach one another and ask them these kinds of tough questions, because we know that we have an opportunity to make a difference, to intervene. Then if you stop someone from killing themselves one way, they'll probably just go and find another. This is the argument for means safety. Means safety or means restriction is actually the most evidence-supported suicide prevention measure we know. And what means safety is when you put a little bit of extra time in the way of someone who's acutely suicidal and them having the means that they're going to use in their hands. And we see lots of opportunities throughout history about how this actually brings suicide rates down. Going all the way back to the late 1950s in Great Britain, they used to use a very toxic coal gas in their stoves. It had a high carbon monoxide content, and people were killing themselves by asphyxiating themselves with the gas that they cooked with. That's where the expression, put your head in the oven, comes from for suicide. And so in the late 50s, they started phasing that out and replacing it with gas like we have. And when they did that, they reduced their carbon monoxide poisoning overdoses by 1/3 without seeing an increase by much in other methods. So again, when people couldn't do it the way that they had planned, it gave time for that ambivalence to start to work, and they very often changed their minds. In England, again, in 1998, they were having an issue with Tylenol overdose. And so they passed a rule there where they have to sell Tylenol and acetaminophen products in blister packs, where they punch the pills out one at a time. So it takes just 2 extra minutes to get that lethal handful of Tylenol. And when they did that, they reduced their Tylenol overdoses by 44% over the next decade, right? We buy Tylenol in bottles of 500 at BJ's and Costco and Sam's, right? That's what I have in my house. Takes a split second to get a lethal handful of Tylenol. So we don't have the same efforts at means safety that some of these other countries have engaged in. And then we have lots of examples about how making it a little bit harder to get a firearm saves lives. So in New Zealand in 1992, they passed a mandatory lock law, and they were able to reduce the suicides of youth by firearms there by 66%. In our country, 85% of youth who die from a firearm suicide use a family member's gun that's already in the home. And in Israel, in the military in 2006, they passed a rule where their military personnel, when they go home on the weekends and on leave, they can't take their guns home with them. They have to leave them on base. And when they do that and they don't have their guns when they're having stressful encounters with their spouses or dealing with financial problems or their kids, they were able to reduce their military suicides by 40%. You know, just by making it a little bit more difficult to get a lethal means at the time that somebody is suffering with those thoughts. And so similar to the way we think about harm reduction when it comes to substance abuse, we think about what can we do to make it even just take a couple extra minutes to get that lethal method available to us, right? We know that especially in states like Kentucky, where I am today, people like their firearms and they don't want to give them up. But if you can convince them to store the ammunition separate so that they have to even walk across the house to get it, to fill their gun. and it takes just those extra 2 minutes, you can actually save a life and give time for that ambivalence to bubble up and they might change their minds. So we have to think about it in a harm reduction way. And it's why we actually work with the firearm community now instead of against them when it comes to suicide, because we know that they need this information, they want this information, and they don't want 2/3 of all the gun deaths in the country to be suicides, right? There's a gun project in New Hampshire that works with gun store owners, and they give them these questions. And a gun shop owner there told us when we were there, you know, I don't want to sell a gun to someone and then find out on Monday that they used it to kill themselves and left, you know, 2 kids without a father. That gives me tremendous guilt. I'm happy to have this information, happy to know where to refer folks if they are depressed. So we make sure that, you know, gun shop owners and range owners are actually getting this kind of information. But it's not just where people get guns, but wherever they get their lethal means, we can put these kinds of questions. So there's a program that trains pharmacy students how to ask the Columbia questions so that if they are worried about someone they're filling a prescription for, they can ask. And we train transit workers on our subway and train platforms. Now, we used to take a very medical model approach to suicide prevention, where we would train psychologists and psychiatrists and social workers how to identify risk and how to treat people with medication and psychotherapy. And that works, but only for the people who are coming in for that, right? And so it didn't make a real dent in the number or rates of suicide. And so what we feel now is that we have to take a more public health approach to this issue. And that means targeting a whole community by doing more universal screening instead of targeted screening, where we give this kind of information to everybody who is potentially able to identify someone who's at risk and then bring them in to get some help. So in a school, that means training all of the teachers and all of the coaches and all of the dorm RAs in the colleges. In healthcare, it means training the secretaries and receptionists who may have a relationship with a patient that the doctors don't have because the doctors see them for 15 minutes, but the receptionists hear them on the phone, know what's going on with them. It means giving this information to every employee in a hospital environment. And we learned this from the Marines. The Marines were the first branch of the military that we worked with. And when they came to us, they didn't want us to train their behavioral health staff. They asked us to train their clergy and their financial aid counselors, their sexual assault advocates, and their lawyers. Because the #1 precipitating event before a Marine suicide is a legal problem. So they get arrested for a DUI or a domestic violence charge, and they're ending their lives by suicide because of the impact that could have on their military career. And so in the Marines now, every time a lawyer meets with a Marine, the lawyer screens with the Columbia and then takes them to behavioral health once they've identified someone who might be at risk. And so we really believe that everyone everywhere can and should ask these kinds of questions. In Vermont now, they have a policy recommendation for schools where everybody from the cafeteria workers to the janitors will get trained. Just yesterday, Dr. Posner was in Washington meeting with the VISN leaders for all of the VA about getting every VA non-medical employee trained, from the cemetery diggers to the canteen employees. And we believe that we need to cast this wide net if we're going to make a difference. And it's why we produced these ACE cards that you got when you came in. They have the Columbia questions on the back, the short screener version, with very clear identification of what the high-risk answers would be and instructions that you can take somebody for a mental health evaluation if they have one of these high-risk answers. And so we started with these in the military. They told us about, they asked us for these in the Air Force. But then we made them for schools that say, ask your students. We made them for parents that say, ask your kids. We make them for social workers that say, ask your clients. And you can make these for any audience or population that you might be working with in your community. You're welcome to change the pictures on them so that they match the group that you're working with. You can change the language on the front as long as the back stays the same. And you can download these templates right from our website, and we're happy to work with you to make them fit for your community. You can add your own logo to it. You can add your own crisis hotline number, whatever's going to make it work in your community. So I'm going to show you a demonstration video of someone asking these screener questions in a peer-to-peer way. This was made by the Air Force Marines. The Air Force chaplains for their internal training. But I want to give you a sense of how you might hear somebody ask these questions. I'm going to apologize ahead of time for how abruptly he gets into asking about death, because we didn't want to take 10 minutes to sort of build up to it gently, so he gets into it pretty quickly.
Come on.
Airman Powell, hey, how's it going? You look frustrated.
Yeah, I'm just trying to come back from leave and let's work.
How did it go? I knew you were looking forward to that leave with your family. How'd that go?
Yeah, I was. Wish I was still on leave just so I had more time, but
You're pretty frustrated, huh?
It was, I'm separating soon, and just being back home and just made things more difficult, and I don't know, it's whatever.
Yeah. You don't really look yourself, Maybe, you mind if I ask you a few questions?
Yeah, that's fine.
Do you wish that you were dead, or that you could go to sleep and just not wake up?
Going to sleep, that sounds pretty good.
So, have you actually had any thoughts of killing yourself?
Yeah, I have.
Well, thanks for being honest with me about it. So have you been thinking about how you might do this?
Oh, I have this gun at home, so,
Yeah. Have you had some intention to act on these thoughts?
I don't know, I clean it and I'm sitting there with it for a while and just, I don't know, things creep into my head and I don't know.
Have you started to work out or worked out the details of how to kill yourself?
Other than sitting there, holding it, and maybe using it, I don't know, it would be so easy.
Right. And thanks for being honest with me. Do you intend to carry out this plan?
No, I think about it sometimes, but...
So have you done anything, started to do anything, or prepared to do anything to end your life?
No, not yet.
Well, thanks again for being honest with me. I know you're having a tough time right now. I can tell that. And I'm concerned about you. I think we should go talk with somebody, make sure that you're squared away. How does that sound?
Yeah, I guess so.
Okay.
So the Air Force has gone the farthest towards creating this whole community approach to prevention when it comes to suicide. And they're actually the only branch last year that had a reduction in suicides. But they've provided this kind of training to all of their support workers, like clergy and financial aid counselors. But they've also given one of these ACE cards to every single airman in the Air Force, and one for all of their spouses. They trained their primary care and dentistry staff. They've trained in all of their schools and their Department of Child and Families. And as an afterthought, all of their behavioral health staff. So we know that we need to screen. We need to screen because it identifies and saves lives. We know that nearly half of all people who die from suicide see their primary care doctor in the month before they die. And we know that 2 out of every 3 adolescents who have made a suicide attempt come to the ER for a non-psychiatric issue. And we have plenty of opportunities there where if we were asking these questions the same way we take other vital signs, we would be able to identify these folks who need help and are slipping through the cracks. And we know screening programs work. John Mann did a study back in 2005, a meta-analysis that showed that screening results in reducing suicide rates in adults. It better identifies depression in elderly primary care. A high school screening program showed that it better identified kids who need help than just allowing the social workers and counselors to go out and find them on their own. And a college screening project where they screened anonymously so that they didn't even know who was at risk actually showed that it increased the likelihood that students would come to counseling later on in the year when they were needing it. So just talking about this actually increases the help seeking of folks. So we know we can prevent it. We can prevent it by identification and then providing treatment, means safety education. But first and foremost, we have to identify, and the problem in the field of medicine for many, many years was that we didn't have a common language for talking about suicide. So you would see the same exact suicidal behavior, and it would be called 6 different things by 6 different people, called a suicide threat or a suicide gesture or parasuicide, non-serious suicide attempt. And we didn't really know how much risk to assign to all of these different definitions, different descriptions. And that not only affected our ability to identify risk, it also affected our epidemiology. So we weren't able to really compare what was happening in one community to another. And so the Columbia actually has fixed that problem in dramatic ways. The Columbia scale was developed about 12 years ago as part of the first NIMH study looking at adolescents who had made a suicide attempt and what was helpful for them after discharge from the ED. It was done at University of Pennsylvania, University of Pittsburgh, Columbia, NYU. And it involved a dozen or so of the top suicide researchers at the time. Those researchers brought together all the tools that they had for identifying risk and realized that there was nothing that they could use to really identify imminent risk and to track change over time. So they pulled together the questions on the Columbia based on all of the evidence-based questions that were predictive of risk for suicide. Since that time, it's appeared in over 1,000 studies, but it's been scientifically demonstrated effective in over 100 studies. It's available in 140 languages. English and Spanish are on our website. You can download them, but we have 130 something other languages if you need one. It takes just a very short time to administer. You saw in the video, it took just a couple minutes to do the screener. And even somebody who is densely suicidal and has a long history takes just a handful of minutes to do. It's good for all ages. It was originally designed for adolescents, and there is research showing that the standard version that you have in front of you has been effective for kids as young as age 6 on up to the elderly. And the definitions that the Columbia developed are now the definitions that the Centers for Disease Control and the Department of Defense all use. And the Centers for Disease Control has this document for researchers that has a link to the Columbia site, but it also has a list of the words we should stop saying. Things like suicide threat and suicide gesture that have a derogatory sort of judgment about them, but also things like completed suicide and successful suicide, right? You complete a job and you're successful at work, and we want to take those positive words away from suicide. And so the recommended language now is to just say died from suicide or ended one's life by suicide. And survivors who have lost someone to suicide tell us that they would prefer it if we didn't use the terms committed suicide anymore as well, because it makes them feel like their loved one committed a crime. And so similarly to how we're talking about addiction, we want to talk about suicide the same way by just saying somebody died from suicide without any other kinds of language around it. Now, Centerstone is, as you know, because you have Centerstone here in Kentucky, one of the nation's largest providers of outpatient behavioral health care in the United States. They are the poster agency for the zero suicide model of healthcare, and they have their policy involves screening every single client at every single delivery point. So when they come in for medication management, and then they see a case manager, and then they have a group therapy, they get screened with the Columbia 3 times in that same day. And they just have made it part of their sort of natural communications with their clients by telling them, look, I know this is redundant and, we're asking this a lot, but we really need to be able to catch this, because if we don't keep all of you safe, then we're not really doing our job. And they report that their clients have, been okay with that. And it's because there are really only, 2 initial screening questions, and most of the time those are no. And if they're yes, then they trigger the sort of further assessment. So they ask those, 2 screening questions every time they see somebody. And if they score positive, they get placed into this suicide-safe pathway of care, where their name changes color in their EHR so that every single provider that works with them will know that they're on that suicide-safe pathway. They get education on means safety. They get weekly therapy appointments. And if they don't show for one of their appointments, they have a dedicated call social worker who does phone outreach to them on a continuous basis until they can re-engage them in services and get them back into the clinic. And they reported, after first doing this in the state of Tennessee, that they had a 65% reduction in the first 20 months of suicides of their outpatient population. And that's why this is the Zero Suicide model. If you go to the Zero Suicide website by the National Action Alliance, you'll see Becky Stoll from Centerstone doing some of their videos talking about their program. But the Zero Suicide model involves identification with the Columbia and safety planning with a safety plan tool that provides a tool that they can use once they're discharged or sent home after their initial crisis appointment. Now, let's talk about the instrument, the Columbia itself. The Columbia itself, in its full form, is this 2-page document that assesses both suicidal thoughts and suicidal behaviors. And it assesses ideation in 2 different ways. First, it assesses the severity of their thoughts, which is a 1 to 5 rating based on which question they say yes to, the last question they say yes to, and those questions 1 through 5. Those 5 questions appear on both the full version and on the short screener. And they start with a wish to die, which is, as you heard, was question 1, and they go through having a plan with intent to act on the plan. Then on the full version, there's a second ideation section on the intensity of thoughts. And so that's, if they did have thoughts in the first section, there are follow-up questions about what happened when they had those thoughts. Then we go on to behaviors. And behaviors, for the first time, we assess all relevant behaviors to suicide. It used to be that the only behavior we asked about was an actual suicide attempt. And when that was the only behavior we asked about, we were missing people who had practiced tying a noose, or who went online to investigate ways to kill yourself, or put a noose around their neck and took it off after they changed their mind. Things that we know now have just as much risk for someone who's going to make an attempt, but are behaviors we never used to know that were important to ask. And then the final section is on lethality of any actual attempts that they made. But it's a semi-structured interview tool, which means that there are probe questions on the form that you can ask exactly the way they're written there. But you don't have to ask them all or in the same order or with the same language. As long as you're collecting the information that you need to collect, to go back afterwards and say, yes, they had this, and no, they didn't have this. But most people, when they first start using it, use it exactly the way it's written. Another good aspect of the Columbia is that you can use multiple sources of information. And that can be really helpful if you have a patient who is refusing to answer, or you have a very young child who may be unable to answer. You can use the parent's report or the caregiver's report or a past medical report to fill out the answers. The Columbia is actually used quite frequently in research on Alzheimer's. And that's because There are stages of Alzheimer's where the patients will answer for themselves, but when they get to a phase where they can't, they ask the caregiver. And they say, what did you see or hear over the past week? Now, again, the full ideation section is 10 questions. The screener is those same first 5. They start with, have you wished you were dead or wished you could go to sleep and not wake up? And then, have you actually had thoughts of killing yourself? If question 2 is no, you skip 3, 4, and 5 and move on. But if question 2 is yes, they have had thoughts, you'll ask, have you been thinking about how you might do that? So do you have a method in mind? Have you had these thoughts and some intention of acting on them? And have you developed a plan, worked out the details of how to kill yourself? And do you intend to carry out that plan? You can't have a method or intent to act or a plan with intent if you never had a thought, which is why you can skip 3, 4, and 5 if question 2 is no. And the evidence shows that as you increase through these questions, your odds of making an imminent suicide attempt increase from about 5 times for the first question on up to about 19 times for that 5th question. So again, let me show you somebody asking those first 5 questions, because I think the more you hear these asked, the more comfortable you become with them, and the easier it becomes to ask.
So tell me, what brings you to see me today?
I've been feeling kind of crummy, problems with my family, and things at work aren't going so well.
Have you been feeling depressed?
Oh, I've been crying a lot, and it's hard to get out of bed in the morning. I guess you could say I'm depressed.
I see. So tell me, over the last month, have you wished you were dead or wished that you could go to sleep and not wake up?
Sometimes I think things would be better if I were dead.
I understand. But do you actually wish you were dead or want to be dead?
Now and then, yeah.
And have you actually had any thoughts of killing yourself?
Yeah.
And have you been thinking about how you might kill yourself?
Sometimes I think about jumping in front of a train or a bus.
But you wouldn't really do that, though.
No way, no way.
See how asking the wrong question can shut down the conversation? Watch now how asking the right questions using the prompts on the C-SSRS can get you more accurate information.
Sometimes I think that I'll jump in front of a train or a bus.
Have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
No, nothing specific.
Thank you for being so honest with me.
Thank you.
So in the example you just saw, the answer circled would be a 4, intent only, not intent and a specific plan. In this next example, a 5 would be indicated. Watch.
Sometimes I think that I'll jump in front of a train or a bus.
Well, have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
Yes. I got a subway schedule, and I saw that there's a station that between 7 and 8 o'clock at night, there aren't many people there, and that's what I was going to do.
Well, do you intend to carry out this plan now?
I worry that I might.
Okay. Thank you for being so honest with me. We're going to get you some help right now.
Thank you.
You see, it would be a 5 because he had intent and a specific plan with the intent to act on it, all the details worked out, etc.
So what's the difference between a method and a plan? This patient reported he first started thinking about killing himself when he was 12. He thought about how easy it would be to pretend to fall in front of a bus so it would look like an accident. Although he thought about it often, he said he didn't have the courage to do it. Is that a plan or is that a method? And I'll tell you that's a method. A plan is more detailed. So a plan is something like, next Wednesday at 3 o'clock when my mom works the late shift and she won't be able to stop me, I'm going to take all the pills that we have upstairs in the kitchen. It has a what and a where and a why about it. So if you're doing the full version, which is generally used more by behavioral health who are doing more treatment with folks, then you have these additional follow-up questions about ideation. And those are questions about the frequency of the thoughts, when they have them, the duration, how long they last, whether or not it's easy or hard to control those thoughts, whether they have any deterrence to acting on their thoughts, and what are the reasons for their thoughts. Is it to stop the pain they're in, or is it to make something else happen? And so logically, if thoughts are happening more frequently, if they last longer in duration, if they are impossible to control, if they have no deterrence, and if it's to stop pain, then you would worry more about someone. And so you can add up the multiple choice answers in this section and you'll get a score of something between 2 and 25. But there is no scientific cutoff for risk for this particular section, which is why it's not part of the short screener. But it does give you real good information if you're doing ongoing work with someone to see if they're getting better or getting worse. So it's nice information to collect if you're doing treatment with somebody. And if you are working with adolescents, Cheryl King, who does work exclusively with adolescents, found that that second question, duration, is the most predictive question for teens. So if teenagers are thinking about killing themselves and it's lasting all day long, they can't get it out of their head, it's running on a constant loop, that's when you would worry most about a teenager. So then we move on to behavior. On the full version, the behavior section involves these 4 separate behaviors, and they start with an actual attempt. And the definition that we use and CDC and Department of Defense uses for a suicide attempt is that it's a self-injurious act undertaken with at least some intent to die as a result of the act. And there are 3 important parts to that. The first is that it says self-injurious act. It doesn't say self-injury. There actually doesn't have to be any self-injury, any injury, for it to be considered a suicide attempt. So if somebody puts a gun to their head and pulls the trigger, but the gun fails to fire, as soon as they pull that trigger and there's potential for injury, then it becomes an attempt. The second part, it says at least some intent to die, where some is the important word. As long as there is non-zero intent to die, it qualifies as a suicide attempt. So very often people will have mixed motivations when they make attempts. But as long as a little bit of them wants to die when they do it, then it is in fact a suicide attempt. And then it says as a result of the act, meaning that they have to have connected that behavior to the wish to die. They have to be doing that behavior because they want that behavior to end their life. Now, on the Columbia, you can infer intent, and you can do that in 2 different ways. The first is that if somebody denies that they were trying to kill themselves, but they know that what they did could kill them, and they did it anyway, then you can call that a suicide attempt. Or in what we call clinically impressive circumstances. That's where what somebody does is so highly lethal that you wouldn't call it anything else. That's the person who takes 200 pills or sets themselves on fire, jumps from the 9th story. If any layperson would say that that was a suicide attempt, then we can call it a suicide attempt as well. Now, a suicide attempt begins with the first pill swallowed or the first scratch made with a knife as soon as there's potential for injury. And the first couple questions to get you started are, have you made a suicide attempt, or have you done anything to harm yourself, or have you done anything dangerous where you could have died? And that can help you get started. Now, the reason why we have all of these questions about suicide attempts is that we're trying to differentiate them from non-suicidal self-injury. Non-suicidal self-injury happens much more frequently than suicide attempts, and it's when somebody engages in self-harm behavior and it's purely 100% for a reason other than ending their life. It's usually for one of 2 things. It's usually either to change how they feel on the inside, so they're feeling a lot of emotional pain and cutting or burning their skin distracts them from that emotional pain, or they're feeling numb inside and those self-harm behaviors release adrenaline, which makes them feel like they're present and alive. or to affect external circumstances. That's the person who pretends they're suicidal because they want sympathy. So they go to the roof and pretend they're going to jump. Or the person who wants to get admitted to the hospital because they're homeless and they need a place to sleep, so they pretend they're suicidal. And if you do the full version, you'll see that this is the actual attempt section. And it has this boxed in question that's indented, or did you know that you could have died from what you did? That can remind you that you can infer. And it also at the bottom has subject engaged in non-suicidal self-injury. Now the authors put that there because when they were doing an evaluation of someone and they found that after asking all these questions that it was not a suicide attempt, all they were doing was checking no for this part of the form, and they didn't have a place where they could show that they asked all the right questions and it was non-suicidal self-injury. Now, the other three behaviors that we never used to ask about are starting with an interrupted attempt. That's where someone starts to take steps to end their life, but someone or something stops them before they actually do anything. That's the person who picks up a gun and somebody pulls it out of their hand, or they're on the ledge ready to jump and someone pulls them back from the ledge. And you can ask, has there been a time you started to do something to end your life, but someone or something stopped you? Then we have aborted or self-interrupted attempts. That's when someone starts to take steps to end their life, but they change their mind. They stop themselves. And that's the person who's planning to drive his car off of a cliff, but halfway there, he turns around and comes back home. Or the person who picks up a gun and then puts the gun back down. And you can ask, have you ever started to take steps to end your life, but changed your mind or stopped yourself before you did anything? The importance of this question came when we were training at a hospital in Detroit. And they told us about a patient they had in there who had driven his car into a wall in a suicide attempt. Incidentally, a large number of our single motor vehicle crashes are actually suicide attempts. And when they had him in the ER, they asked him this question, and he said, you know, there are 4 other times that I drove really quickly at that wall, but I stopped before I got to it. And no one's ever asked a question like that before. So now imagine if he was at his primary care doctor a week earlier for a physical, and they had asked these questions. Maybe they would have found him before he actually had that injury and made the attempt. Then finally, we have preparatory behaviors. That's any other behavior that has suicidal intention behind it. That's things like getting the means together that you're going to use in an attempt, giving your valuables away, writing a suicide note, looking up ways online to kill yourself. And you can ask, have you ever taken any steps towards making an attempt or doing any of these things? And you can give them these examples. When we were training at a hospital, a VA hospital, they told us about their most recent death was a veteran. He was in his 70s. He had been in to see his doctors. They had asked him their usual questions. Upon his death by suicide, though, they found that he had been putting clothing in bags and labeling them for different charities and stockpiling food for his pet. For 6 months, he was making preparations for suicide. And they said to us, we had no way of stopping him because we didn't know this was an important question to ask. You know, maybe we wouldn't have caught him, but maybe, you know, we would have. And, you know, we think that by asking about all of these kinds of behaviors, like preparatory behaviors, we may even be able to find kids like Dylan Klebold, one of the Columbine shooters, before these kinds of things happen, because he wrote more than 5 times in his journals that he didn't fit in here and thinking about suicide gave him hope. Or even the Santa Fe shooter in Texas last year had written in his journals that he wanted to kill people and then kill himself. And the evidence shows that each one of these 4 behaviors has an odds ratio of 5 times for somebody making an imminent suicide attempt. Now, this graph is a look at 30,000 administrations of the Columbia. And what it shows is that after, when we did this 30,000 times, we found that of the worrisome behaviors, only 13% were actual attempts. 87% of the worrisome behaviors were these other 3 behaviors that we don't normally ask about. The other thing that this graph shows is that people worry a lot if we start screening everybody who walks in the door. Aren't we going to have tons of people that we have to do follow-up with and lines around the clinician's office waiting for people to be seen? And what we see time and time again is from all of these places that are doing universal screening, that it's about 1% to 2% of people who will have these worrisome answers. And so in this particular case, of the 30,000 folks who were screened, these were depressed study subjects. And so of 30,000 depressed study subjects, they had 1.7% of them had worrisome answers. And when we reran this with 50,000 administrations, we had just 0.9% were positive. Now the final section on the full version is lethality. That's for any actual attempts. How much medical damage happened? So if it was a cut, did it bleed a lot or a little? Did you have to get it bandaged or stitched? And you're just going to ask a few questions about how much medical damage happened. And the very final question is on potential lethality. That's for any actual attempts with 0 medical damage. You'll ask, or you'll actually score, if they tried that same thing again, what's the likely outcome next time? And that's there for those rare cases where someone does pull a trigger on a gun and the gun doesn't go off, or they lay down on train tracks and then get back off before a train comes. They wanted a place where they could show that even though there was 0 medical damage, that was a pretty lethal attempt. So I'll show you one more video of somebody asking these these behavior questions.
Have you made a suicide attempt in the past 3 months?
No, not really.
What do you mean by not really? Have you done anything to harm yourself?
Well, last month I took a handful of pills because it's like even my parents can't see how much pain I'm in.
Did any part of you want to kill yourself? Or was it 100% to get them to pay attention to you?
I guess a little bit of me wanted to die. Either way, I would have been better off.
Were there any other times you did something like that?
No.
Okay, I see. And in the past 3 months, have you ever started to do something to end your life? But someone or something stopped you before you actually did anything?
A friend of mine took a bottle of pills from me because I was thinking about taking them.
Was there any other time that happened?
No.
Okay. And has there been a time when you started to do something to try to end your life, but you stopped yourself before you actually did anything?
No. Not that I can remember.
Have you taken any steps toward making a suicide attempt or preparing to kill yourself, such as collecting pills or getting a gun, giving valuables away, writing a suicide note?
I wrote a note to my friend telling her that she could have my CD collection if anything ever happened to me.
Is that the only thing you've done like that?
This one time, I put a bottle of pills underneath my pillow. You know, just in case.
So, just those 2 times?
Yes.
Thanks. I appreciate how honest you've been. So, when you took the pills, what happened after that? Did you go to a hospital? Did you seek medical attention?
Well, they were just vitamin pills. So no, I didn't get any medical attention.
I see. Thank you. Let's see if we can get you some help.
Thanks.
Okay, so she had some pretty significant suicidal behaviors. She had an actual attempt, she had an interrupted attempt, and she had 2 preparatory behaviors, and probably very little or no medical damage from the attempt that she made. So when you're doing behaviors, you're going to check all the behaviors that apply, but only if they're discrete behaviors that are part of a single episode. So in that example, if the pills that she kept under her pillow are the same ones that she just took in the attempt, you wouldn't count that twice as two different things. You would count that just as the one actual attempt that she made. It's also important to remember that you do need to ask about behaviors, even if there are no's to all of the ideation questions, because we have seen a rare individual who will say that they made such an impulsive suicide attempt that they didn't have any thoughts prior to their attempt. And then it's important that we listen to what the person believes is going to happen when they do what they do when we're thinking about suicide attempts, and not go with what we think about the behavior. This is really important for very young kids who may do things that seem kind of silly or not lethal, that sometimes they'll put their head into a pillowcase and say that they want to die. It's also really important for folks who might be psychotic and might come up with some very strange ways to kill themselves that we know can't kill you, but in their psychosis they might believe that they can. And so we need to listen to the motivation of the person who we're talking to, which is the most important piece. Now, on the screener, on these community cards, all 4 of those behaviors are combined into the one question number 6. And so it says, have you done anything or started to do anything or prepared to do anything to end your life? And then it lists examples of all 4 of the behaviors there. Now, the time frame that we ask about is very important. And so on the full version, we have one with 2 scoring columns, one for lifetime and one scoring column for recency. Lifetime doesn't tell you about what you need to do for someone today, but it can tell you about their overall lifetime risk for suicide, and tends to be used at intake for an inpatient or outpatient behavioral health stay. And so for lifetime, for ideation, you're asking about the time they felt the worst in their lifetime. And that's because Aaron Beck showed that the time someone feels the worst in their life or the most suicidal, even if it was 30 years ago, tells you a lot about their lifetime risk for suicide. But to figure out if someone needs to be hospitalized today, we're asking about the past 1 month of their thoughts and the past 3 months of their behaviors. And that's because when the authors were collecting initial data, they found that after 1 month of being free of thoughts and after 3 months outside of a behavior, the risk of making an attempt in the next few days or weeks drops by more than 50%. And it doesn't drop to 0, so you're not at no risk if you've had a behavior and it was 4 months ago, but your risk is significantly decreased enough that that person doesn't need to be inpatient or be on one-to-one observation. And we believe that monitoring is critical. So the same way that Centerstone is doing this every time they see a client, we believe that all you have to do is use one of these versions in the since we last asked you time frame for follow-up monitoring. And so this is how it's being used on outpatient every week or inpatient units every nursing shift. We have it done on some hospitals every day shift on nursing, so every 8 hours. And it's because all you have to say to someone is, since the last time we were in, did you have any thoughts about suicide, or have you done any of those things, those behaviors that we talked about? That's all you have to ask for follow-up. It takes 10 seconds, and then you can check off your mental status form, no suicidal ideation or behavior. And you can feel confident that you did a thorough suicide ideation, suicide behavior check. Now, and 99% of the time, those answers will be no, and you're done. And those rare times when the answer is yes, that's when you can pull out the sort of more detailed questionnaire. So what do we worry about? The high-risk answers are a yes to question 4 or 5 or 6. So having a yes answer to ideation of a level of 4 or 5, which is when you have intent to act on those thoughts. Now, we used to think it was a plan that was important, but the plan's not as important as the intent to act. So you can have intent to act without a plan, where you're saying, yeah, I'm going to kill myself. I'm going to do it next week. I just don't know how I'm going to do it yet, or I don't have the details. As long as you have intent to act, your risk is high. Or having any one of those 4 behaviors within the past 3 months. That's when your risk is high. And these scientific thresholds really take a lot of the guesswork out by providing you with information that can be proscriptive for what to do next, but is also flexible enough to allow for the necessary clinical judgment when there are cases where there are mitigating circumstances. So we're never going to have a perfect test for figuring out if someone's going to attempt suicide in the next week until we can really read people's minds, and I don't see that on the horizon. But you know, having the most scientific questions that give you the potential information that you can then combine with your clinical judgment is about the closest that we come, and the Columbia is what gives you that. Now, I think one of the biggest benefits of the Columbia is really in figuring out who doesn't need to go to the ER, in being able to sort of screen out those low and moderate risk folks. So let me show you how a teacher or a first responder might use it in that fashion.
Situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to C-SSRS, and I could use a few quick questions to help me decide what level of care she needed. Hi, are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm gonna ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that, all right?
Okay.
Good. Have you wished you were dead or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
Asked her questions 1 and 2. She said yes to 1, no to 2. So we skipped 3, 4, and 5. Asked her the behavior question. She said, I had a behavior, but it was a long time ago. So this is someone who's at moderate risk or low risk. And his next step with her, you know, would be more like, do you have a therapist that you work with in the community? Do you have an appointment coming up? Can we call and make an appointment for you? If you don't, here's a list of community resources. In fact, we're standing in front of Columbia Psychiatry because I filmed it behind our building. Incidentally, he's an extra on Law and Order. They come with their own uniforms, these actors in New York City. You know, so I want to give you the hotline number. I want to tell you that if you start to feel worse, you can call us back. And do you have a friend or a family member we can call who can spend the afternoon with you, you know, so you don't have to be alone. But this is someone who in the past, he would take her to the ER because he heard she wished she was dead. And he would be not doing his job on the streets. And she would sit in the ER for 6 hours and then get evaluated and then get sent back home. And we know that people who get evaluated in the ER when they don't need to are actually turned off from care. It actually reduces the likelihood that they'll follow up with treatment. And so wherever you use the tool, the same high-risk answers indicate one-to-one observation until you can get them evaluated. And so if you're in a school or a jail or an ED, high-risk answers are a yes to 4 or 5 in the past month or 6 in the past 3 months. And our toolkit is really flexible, so you can use the short screener or the full version. You can add to either of those a checklist of risk and protective factors. The state of Tennessee, for all of their crisis assessments, has chosen to use the short screener and our checklist of risk and protective factors. Those include risk factors that the authors felt were warranted by the evidence at the time, and protective factors that might reduce their risk. So they include things like having being a perpetrator of violence, having a chronic health issue, having a substance abuse problem, having a family history of suicide, having your own history of sexual or physical abuse, having self-injurious behavior without suicidal intent, being anxious or agitated, And they include social and environmental risk factors like having a recent loss of a relationship or a job or your home, feeling like you're a burden on your family, not being able to agree to treatment or a safety plan, things that increase your lifetime likelihood of suicide, but again, don't tell you about the imminent risk like the Columbia questions do. And protective factors like identifying reasons to live, feeling a responsibility to take care of family or other people, having a supportive social network, believing that suicide's immoral or having a high spiritual practice, having a fear of death. And we've also taken these risk and protective factors and our Columbia questions and combined them into a format that SAMHSA has recommended called the SAFE-T. And so it just takes our questions and puts them into a 5-step process where you'll be asking the questions in a certain order and then making an assessment of high, moderate, or low risk at the end and documenting your answers. All of these forms templates are all available on our website. They're free to download. All of the Columbia tools are absolutely free for you to use, courtesy of the pharmaceutical industry. The pharmaceutical industry has to use the Columbia for all of their new drug research to make sure that their drugs are safe, and so we make them pay. And as a result, all clinical use for the tools is absolutely free. You can add questions to the Columbia if you have a certain population you're working with certain risk factors you want to know about up front. You can certainly add questions to it. So in Schenectady, New York, they had a gang-related suicide problem where teenage girls who were stuck in a gang were killing themselves because of the inability to free themselves from that gang. And so they added questions about gang involvement. A military version added questions about how many deployments, what the state of service is, those kinds of things. And we now have the short screener on a mobile app. So if you go to one of the app stores and look on Columbia Protocol, you can download an app that will take you through those 6 questions. And depending on which answers you answer yes, we'll spit out at the end high risk, moderate risk, or low risk, and tell you if you're high risk to immediately seek some mental health evaluation. And as you can imagine, this is having a big impact on care delivery. You know, the PHQ-9 is a typical tool that we used to use for assessment for depression and suicide. It's a great depression assessment tool, but it's a pretty poor suicide assessment tool. So the 9th question, which is the suicide question, says, thought you would be better off dead or of hurting yourself in some way. Better off dead is not considered suicidal by suicide researchers. It doesn't increase anyone's risk for suicide. And hurting yourself in some way can be non-suicidal self-injury. So when Cleveland Clinic did a study looking at 523 patients with the PHQ-9 and with the Columbia, they found that 24% said yes to that 9th question, and it was only 6% with the Columbia. So they ruled out 18% false positives by just adding a couple extra questions in the Columbia. And this is at Reading Hospital in their ED. After implementation of the Columbia, they saw 1-to-1s drop for every single quarter after they implemented. That blue line are their 1-to-1s in psych consults after implementation. The red line is their average before implementation. Centerstone recently reported to us they reduced ED recidivism of their outpatient population from 40% to 7% in the last year. And schools are typically an area where they refer kids, at the slightest sign of anything depressive because they're scared and worried about the kids. But when we can give them a tool like this where they can better identify those kids who need to go, it not only saves money, and time and gets the right kids the right care, but it also prevents these unnecessary ER holds where, parents and kids are sitting in the ER all afternoon and they don't really need to be there. So remember I told you were only going to have about 1% worrisome answers. So we told that to the VA hospital in Detroit and they laughed at us and said, come on, 1 to 2% are going to be high risk. We're the VA, we have a high risk population. So they took a look at 3,000 veterans who were seeing a psychiatrist. So veterans with a mental health issue. And when they screened 3,000 of them, they found 14 of them had positive screens, or 0.5%. And of those 14, 5 of them needed to be hospitalized. So again, they found 5 people out of 3,000 that they would have missed having not screened with the Columbia. And Parkland Hospital in Dallas, Texas is the first hospital to do universal screening. So they screen every single patient at every single time they come in for any single procedure. And they reported out after their first 100,000 patients were screened that they had 1.8% were positive and needed follow-up. And so they have 13 or 12 psychiatric social workers that are in charge of doing that follow-up. And so they meet with the patients that screen positive and decide what the next steps are going to be. And Kim Roatten, Kim Roatten down in Texas is a great resource if you're interested in talking to someone who's actually implemented in a universal way across a hospital system. And people ask us all the time, if we start screening everybody, aren't we opening ourselves up for a liability problem if something bad happens? And what we know from medical malpractice attorneys who were interviewed for a magazine article about the Columbia is that if you're doing the scientifically best gold standard measurement there is, which we believe the Columbia is, and you're documenting your answers and doing the right next steps based on what's recommended, that's the most protection you can have, right? In a mental health field, there's always some risk, right? But you minimize that risk when you're doing something scientific and you're using it the right way. Someone else said recently, people don't get sued for bad outcomes, they get sued for negligence or malpractice, for not doing something right. And in all of the lawsuits against schools that I know about after a suicide, the ones where people are successful in their lawsuits happen because someone knew something and didn't say anything, right? That's really where your big problem is if somebody hears something but doesn't take a next step about it. And just being handed one of these cards, going to one of these trainings, talking about this issue, actually is an intervention in and of itself, because it creates a safety net of people who know this is important and who aren't afraid to talk about the topic. And that can actually break down the barriers of loneliness that is so common in people who might be at risk for suicide. So that's the end of my talk. We have about 5 minutes for questions, but I'll also stay through lunch if anybody else has questions. And you're also welcome to send us questions through either our website or through Dr. Posner's email address. Yes?
That we have the president of the American Association of Suicidality, that's a professor here at UK, comes out of the College of Social Work. And she's been charged, along with many others at our university, to look at some unfortunate events that have happened this year. So 3 students died by suicide. And I'm curious if you've got any information that might help us, especially when we think about, putting some of these prevention tools, screening these students that we're so concerned about. Are you seeing anything fall out in terms of more at risk on the health profession side of students, or is it those students like the engineering? I mean, we have data that supports 400 physicians take their lives by suicide, but we really haven't gotten good data about other health professions, certainly not nursing. And we are concerned we've got a silent epidemic of nurse by suicide. So can you share any thoughts on that, what you might know?
Well, what I know about the increased risk for the medical professions has to do with their comfort level with pain, that they are around people who are in pain all the time, and so they become sort of immune to pain, and so self-injury becomes something that is tolerable in some way for folks in the medical profession. They also know a lot about what's lethal and what's not, which is dangerous knowledge. And they deal in a stressful environment, that they have people who are depending on them. And that provides this sort of additional stress that increases risk in the medical profession. We see it sort of in general in graduate schools, just because of the increased pressure that graduate students feel compared to undergrads. But I haven't seen anything comparing, one grad school to another as far as the subject matter that they're studying, just grad students in general. But I would say, screen. You have an opportunity to screen, all of your students, and to provide this information to the students themselves so that they can screen their friends. Because again, the crisis happens when they're not in the clinician's office. The crisis happens when they're in their dorm room, and when their friends know what to look for and their friends know where to get help. That's when you might be able to save people. You're welcome.